Intracranial hypertension. Andrea KJN, MSN, ANPBC, ACNPBC. Objectives. Upon completion of this presentation, the participants will be able to discuss the physiology of intracranial hypertension, recognize the clinical manifestations of intracranial hypertension, identify indications for intracranial pressure monitoring, identify specific causes of intracranial hypertension, employ general management measures in the treatment of intracranial hypertension. Intracranial physiology. Normal brain Monro-Kelly hypothesis. Blood-brain CSF. In adults, the intracranial compartment is protected by the skull. There is a fixed internal volume of 1,400 to 1,700 milliliters. http://radiopedia.org/cases/Monro-Kelly hypothesis. Intracranial pressure-volume relationship. Poor compliance. High compliance. Volume. Compensatory mechanisms. http://radiopedia.org/cases/Monro-Kelly hypothesis. Compensatory mechanisms. Regulation of cerebral blood flow. Oxygen. CO2. Metabolism. Cerebral perfusion pressure. CPP equals MAP, ICP. Relationship between O2 and CBF. The brain uses 20% of available O2 for functioning. CBF increased with PaO2 less than 50 mm of mercury. Cerebral blood flow increases maintain cerebral oxygen delivery, CVO2. Relationship between CO2 and CBF. Hyperventilation is one known method of rapidly lowering ICP. Decreased PaO2 leads to arterial vasoconstriction, thus lowering CBF, cerebral blood volume, and ICP. Although the effects of hyperventilation are almost immediate, these effects on CBF diminish over 6 to 24 hours as the brain adapts by changing bicarbonate levels in the extracellular fluid to normalize the pH. CBF. PaO2. Relationship between brain metabolism and CBF. The brain receives 25% of the total body glucose. Adenosine triphosphate, ATP, is the most important energy source for the brain. The end product of anaerobic glycolysis is lactic acid. Lactic acid is toxic to neurons and decreases the pH. Relationship between brain metabolism and CBF in the injured brain. Decreased CBF is frequently seen following severe head injury. It is thought to be secondary to depressed metabolism. Positron emission tomography studies within 8 to 14 hours of injury show reduced CBF and global cerebral metabolic rate of oxygen, CMRO2. Relationship of cerebral perfusion pressure and CBF. CPP equals MAP ICP. A reduction in CPP can result in devastating focal or global ischemia. Excessive elevation in CPP can lead to hypertensive encephalopathy and cerebral edema. A higher CPP is tolerated in patients with chronic hypertension because the autoregulatory curve is shifted to the right. Autoregulation is responsible for maintaining CBF at a relatively constant level by cerebrovascular autoregulation of cerebral vascular resistance, CVR, over a wide range of cerebral perfusion pressures of 50 to 100 mm of mercury. Relationship of cerebral perfusion pressure and CBF. What is intracranial hypertension? Elevated pressure within the cranial vault. Defined as ICP greater than 20 mm of mercury. As Dr. Dieringer would say, it is the ultimate compartment syndrome. Why is intracranial hypertension so important? Without prompt recognition of elevated ICPs, it will lead to decreased cerebral perfusion, ischemia, infarction, permanent neurologic disability, herniation, death. What causes intracranial hypertension? Intracranial mass lesions, cerebral edema, hydrocephalus, idiopathic intracranial hypertension, herniation syndromes 1, uncal 2, central 3, subfalcine 4, transcalvarial 5, infratentorial 6, tonsillar. Pressure gradients and shift. The cranial vault is divided into compartments by the dural reflections of the fall cerebri in the tentorium cerebri. Elevated ICP frequently results in pressure gradients between compartments and a shift of brain structures. Lateral displacement of the pineal gland correlates with lock. Clinical manifestations of elevated ICP: nausea/vomiting, headache, altered lock, pupilledema, anisocoria, seizures, posturing, Cushing's triad, widened pulse pressure, bradycardia, abnormal respiratory pattern, pupilledema. Clinical signs of herniation. CT images of herniation syndromes. Subfalcine herniation, uncal herniation, CT images of herniation syndromes. Downward transtentorial, tonsillar herniation. Rationale for ICP monitoring. Elevated ICP can contribute to secondary injury. Reduces cerebral perfusion pressure, CPP, leading to global hypoperfusion and ischemia. Routine ICP monitoring may be used for detection of delayed hematoma, monitoring sedated patients, determining prognosis. Indications for ICP monitoring: GIS less than 9 and with an abnormal CT scan. Comatose patients with normal CT scan and 2 or more of the following. Age greater than 40. Posturing. SBP less than 90. Types of ICP monitors: intraparenchymal, subarachnoid, intraventricular. Epidural. ICP waveforms: P1 equals percussion wave, represents arterial pulsation. P2 equals tidal wave, represents intracranial compliance. P3 equals dicrotic wave, represents aortic valve closure. Treatment of intracranial hypertension. Positioning HOB: elevated head in neutral position. Avoid tight C collars. Hyperventilation. Acute hyperventilation reduces ICP. Cerebral vasoconstriction, due to rise in CSF pH. Cerebral blood flow, CBF. Cerebral blood volume, CBV. Intracranial pressure, ICP. Effects are temporary. Metabolic consequences of hyperventilation. CBF falls. In order to maintain constant oxygen delivery, extraction rises. Over several hours, CSF pH returns to normal, producing vasodilation, returning CBF and CBV to baseline. Weaning hyperventilation. After several hours of sustained HV, CSF pH returns to normal. Any reduction in minute ventilation results in cerebral vasodilation. Impact on ICP depends on intracranial compliance. Mannitol and hypertonic saline. Osmotic therapy: mannitol and hypertonic saline. Reverse clinical herniation, even with normal ICP. Reduces ICP. thought to work due to osmotically induced fluid shifts, hemodynamic effects. Both agents. Initial blood volume, cardiac output and BP. Mannitol only. Rapidly followed by diuresis, which can lead to hypovolemia. Mannitol therapy rapidly deteriorating patient 4 bolus 1 5 grams/kg. Followed by 0.25 to 1.0 grams/kg Q6 hours. Requires BMP and serum osmolality Q12 hours. Brain relaxation/dehydration. Osmotic gradient with mannitol appears to draw intracellular fluid from brain to serum. Mannitol. H2O. Blood-brain. 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 H2O. H2O. Normal equilibrium. Mannitol infusion. Mannitol equilibrium. Wu CT, et al. Ains Analgesies 2010, 110, 903-907. Rose et al. Anesthese 2007, 107, 697-704. Impact of cerebral autoregulation. Immediate effect of mannitol is plasma expansion. Augmented blood volume increases cerebral blood flow. Compensatory vasoconstriction. H2O. Normal equilibrium. Mannitol infusion. Vasoconstriction. Potential complications of mannitol. Mannitol accumulation in damaged brain. Rebound edema. Renal failure. Mannitol leakage. Mannitol leakage. HS always enter brain interstitial fluid. Mannitol enters brain interstitial fluid if blood-brain barrier disrupted. Does it stay? MRI imaging of mannitol. Pre-dialysis. Post-dialysis. Mannitol therapy must calculate osmotic gap. Difference between serum osmolality and calculated serum osmolality. Calculated osmolality equals Na(x2) plus 1/2.8 plus glucose/18. Use of the osmotic gap. Osmotic gap, difference between measured and calculated osmolality. Identifies unmeasured osmoles such as mannitol or ethanol. Measures DROF to ensure mannitol excretion is complete. Garcia Morales et al., CritChem ed. 2004 32-4, 986-91. Retrospective review of 110 patients receiving mannitol. Urine volume routinely replaced. Mannitol dose adjusted if osmotic gap rises. 11% incidence of renal insufficiency. No relationship to osmolality or osmotic gap. Renal insufficiency predicted by chronic insults to kidneys, DM, HTN. Gondim et al. J. Neurosurg. 2005 103-3, 444-7. Hypertonic saline 23.4% equally as effective as mannitol. Requires central access. 0.686 ml of 23.4% saline is equiosmolar to 1 gram of mannitol. 5%. 3.2 mls/kg. Does not require a central line for emergent dose. Mannitol versus hypertonic saline. Hypertonic saline and mannitol have been compared in a few clinical trials. 2 recent meta-analyses compared efficacy. Theoretical benefits of hypertonic saline. Less volume, 23.4%. Lack of diuretic effect. Reflection coefficient, 1 versus 0.9. Attenuation of macrophage and neutrophil activation. variable immune response. Kamal H. et al. CritChem 2011, 39, 554-559. Mortazavin, et al. J. Neurosurgery 2012, 116, 210-221. Mannitol versus hypertonic saline. Many studies suggest HTS is as good, perhaps better, at reducing ICP compared to mannitol. No clear benefits for safety, except maybe hypotension. Neurologic outcome. Mortality. Therapeutic hypothermia. Rationale: reduces cerebral metabolism. Reduces infarct volume in animals. Appears safe in patients. Very invasive, requires intubation, sedation, paralysis. Reduces ICP, therapeutic hypothermia. Potential complications. Coagulation disorders. Cardiac arrhythmias. Electrolytes shifts. Myocardial depression. Infections. Primarily pneumonia. Therapeutic hypothermia techniques. Therapeutic hypothermia. Applications. Severe head injury. Large cerebral infarction. Cardiac arrest. Neonatal IVH. Early decompressive craniectomy for severe penetrating unclosed head injury. Bell RS, Neurosurg Focus, 2010 Volume 28, Number 5.